Our next speaker is Dr. Sruthi PS, and now we are going away from CSR and PAM to diabetic retinopathy with CSME, or are we looking at something else?
Good morning, all. Is it DME or something else? I am going to present a case of 72-year-old lady. She is a non-diabetic hypertension and dyslipidemic patient and cardiac disorder on treatment. Came with complaints of sudden onset of blurring of vision and floaters of right eye since 3 weeks. She is giving a past history of diabetic retinopathy and laser done in both eyes 15 years back and cataract surgery done in both eyes 20 years back, and her DME is not under proper control also. On ophthalmic evaluation in her right eye, best corrected visual acuity was 6 by 36 in 36. IOP was normal, anterior segment was normal. She is pseudophakic, media showing haziness, AVF cells present, vitreous haze present, and fundus showing evidence of PDR, which was lasered, and other details are hazy. In her left eye, best corrected visual acuity was 6 by 6 N6 and showing a stable PDR in left eye. Then we proceed with OCT in this case. OCT showing a hazy view due to poor signal strength. And we could appreciate changes like IRF, SRF, hard exudates, and a central macular thickness of 430 micron, and associated with temporal thickening also. Suggestive of CME in this case, cause can be PDR or either vitritis. So then we did a B scan. It showed findings suggestive of vitritis, and RCS thickness was normal also. So routine blood investigation was done to rule out other causes of vitritis, like counts were normal, ESR are slightly elevated, Mandos test was negative, serum AC level is elevated, and her blood sugar levels are deranged. So did a pulmonology consultation to rule out sarcoid and TB, and CT just showed bilateral hilar and para-aortic lymph nodes with a few other tiny lymph nodes as well in other locations, and lymph nodes are small, so they didn't do a biopsy for the patient, and cardiac and respiratory evaluation didn't show any evidence of sarcoidosis or TB. So what could it be? A 72-year-old lady, laser PDR with CSME, presented with intermediate uveitis also. She is positive HRCT findings, TB was negative, and serum AC also positive. So why vitritis for this old lady? Is it due to ocular sarcoid or other major differential is primary vitreoretinal lymphoma? So plan to give an IVT injection for the patient in view of vitritis and CME, and 2 weeks post IVT injection, vision improved to 618 N12 and vitritis started resolving, and 2 months down the line the vision improved to 6 by 9 N8 and fovea was completely flat with vitritis completely resolved. So coming to the discussion, ocular sarcoid, it can occur at any age with any different type of presentation. If it occurs in the older age, like after 60 years, it can present with either intermediate uveitis or posterior uveitis also. The vitreous cells are basically inflammatory cells. So along with intermediate uveitis, you can also get posterior uveitis findings like multifocal choroidal granuloma, periphlebitis or vasculitis. Corticosteroid is the treatment of choice in this case. Diagnosis is done by doing a lymph node biopsy, HRCT and serum HRCT and chest X-ray to look for bilateral hilar lymphadenopathy, and serum AC levels and serum lysozyme levels are elevated, and we should rule out TB in these cases before diagnosing it as a case of sarcoid. And on the other hand, primary vitreoretinal lymphoma, this case usually occurs in old age, is a malignancy which masquerades as chronic intermediate uveitis. The vitreous cells are basically the lymphoma cells, that is reactive cells. Along with vitritis, we will get retinal findings like subretinal lesions in these cases. And these cases will not respond to corticosteroids, and diagnostic vitrectomy should be done to diagnose this case, and MRI is a must in this case to look for CNS involvement. So these are the fundus findings showing PVRL and ocular sarcoid. So coming to the revised international workshop on ocular sarcoidosis, other causes of granulomatous uveitis must be ruled out. Intraocular signs, as I said, should be present, and systemic investigation like bilateral hilar lymphadenopathy should be there. Negative tuberculin test, serum AC and serum lysozyme levels should be elevated. Elevated CD4 to CD8 ratio, lymphopenia and other parenchymal lung parenchymal changes should be there. So the diagnostic criteria, we can diagnose as three category: the definitive OS, diagnosis supported by biopsy with uveitis, and presumed OS, diagnosis not supported by biopsy, but BHL and other signs are present, and probable OS, where biopsy is not supported and BHL absent, but other intraocular signs and systemic investigations are positive. So the take home message: proper ophthalmic and systemic evaluation will help you in diagnosis. Vitritis in old age needs to be investigated thoroughly. Management is different based on etiology, and a proper follow-up of findings is necessary in decision making. Thank you.
Very interesting case. The one thing we should always remember is that one pathology doesn't mean the patient will not get another pathology. So when the patient presents with a vitreous haze in a PDR, first thing we think of is a vitreous hemorrhage. And what can differentiate a vitreous hemorrhage from a vitritis? What is that? Anterior chamber inflammation, okay, but many of the intermediate uveitis don't have anterior chamber inflammation. Neovascularization, obviously, if there is, okay, or the color of blood is there, that is the differentiation, but that is not there. You're having just a diffuse thing. It's a simple thing that we should do in the OP. High magnification, anterior vitreous phase, slit lamp examination. If you put your high magnification and look, you can make out whether it is an RBC or a WBC or a pigment. So that has to be done before we jump into the diagnosis that it is a lasered PDR with activity with vitreous hemorrhage, because that is the first point. Second point is, when it is a vitritis, if you are not having view of the retina, let us say that in her case we are not able to make out whether there is macular edema, you are not getting your OCT. Do not inject anything without knowing what is happening in the retina. Even a B scan is not enough, because if you do a B scan, the only information you get is the retina detached or not. That doesn't give you any information as to what is the underlying pathology. So in these cases, especially in the older age group, do not inject your steroid without being able to see the retina, at least finding out what is happening there. So there it is definitely a diagnostic vitrectomy that should be done. Refer the patient for a diagnostic vitrectomy. That will figure out whether it is infective, non-infective, or are we dealing with just vitreous hemorrhage, or are we dealing with some endogenous endophthalmitis. So whatever it is, if you are not having view of the retina, please refer for a diagnostic vitrectomy. If you do have view like she had, and you got an OCT that showed you that there is fluid, you know it is intermediate uveitis with fluid, and it may even be a superadded CSME, because the patient already has a lasered PDR. So there may be a diabetic macular edema element with it, but again your first choice should be steroid and not anti-VEGF, because anti-VEGF has very little anti-inflammatory action, but here you know there are two causes for inflammation causing the edema. So you can take care of both with your steroid. But like she pointed out, you cannot miss out an infective cause, so you have to rule out TB before you inject your steroid. Please, I don't know how many of you attended the first session, 9:30 session on uveitis X files. There was a case where they injected thinking it is vitritis, and the patient had a local decrease in immunity that caused severe toxoplasmosis. So that again is important, because vitritis is the presenting finding in toxoplasmosis, headlight in a fog. And if the fog is so severe that you are not able to see that lesion, you can miss it for an intermediate uveitis. So that is also very important. Before you inject anything into the vitreous, please be clear that the vitritis you are dealing with is non-infective, and then only inject either Ozurdex or triamcinolone. And it will take care of the diabetic macular edema part as well. If the patient is not responding, or if the vitritis is increasing, always take a vitreous biopsy, because PVRL is definite differential diagnosis of vitritis. Lymphomas in the old age is leukemias in the old age is also a differential. Amyloid is a differential. So you may not be dealing with vitritis at all. So definitely send for a diagnostic vitrectomy, or at least a vitreous biopsy. Yeah, I was going to ask you why systemic drugs were not started.
Systemic drugs, basically in bilateral cases, when the topical medication is not responding very well, or if the systemic findings are also there, we can directly start with systemic steroids. But in this case, we treat this with CME, so to look for the CME part also, I directly proceed with injection.
Many times the systemic treatment is dictated by the systemic involvement, and many of these is a sarcoid, it has a 60 to 90% spontaneous remission, systemic sarcoidosis. So because of that, if you just have bilateral lymph node involvement without lung involvement, without cardiac involvement, your systemic physician or lung specialist will not start the patient on immunosuppression. So you can give systemic steroid by yourself, but if you're going to give systemic immunosuppression, you will need help from the pulmonologist, and the pulmonologist will not start with just bilateral hilar lymph nodes, especially not without a biopsy report. Even with a biopsy report, they won't start, because many of them, like I said, have a very high incidence of spontaneous remission. But if you say specifically that this eye involvement is because of sarcoid, it looks very much like sarcoid and I need immunology cover, then you can, for the eye indication, they will give you systemic immunosuppression, and that you should do. If the patient did not respond to local, or if it is bilateral, then definitely we have to go in for systemic immunosuppression, and ocular involvement in sarcoid is an indication for immunosuppression, even if there is no lung involvement. So that but they will do that only if you tell them that this is ocular sarcoid. So you have to be clear about that.